Today, we're diving into a real clinical mystery. How is it possible for a drug to produce symptoms that are a near perfect copy of a serious mental illness like schizophrenia? It's a diagnostic puzzle where getting it right can literally change everything for a patient.
So let's just ask it outright. Can a substance really forge a perfect counterfeit of something as complex as a mental illness? The answer isn't a simple yes or no, and it's a question that clinicians are grappling with every single day on the front lines of care.
And the reason it's such a tough question is because the resemblance is, well, it's striking. When a patient first shows up, the symptoms of meth-induced psychosis and schizophrenia can look so incredibly similar that it creates a huge problem for doctors. I mean, picture this. Someone is wheeled into the emergency room. They're agitated, they're not making sense, and they're completely detached from reality. They're seeing things that aren't there, believing things that just aren't true. The medical team's first, most crucial job is to figure out why, but all the initial clues are pointing in two totally different directions.
So where does all this confusion come from? Well, most of it comes down to what clinicians call positive symptoms. Now, positive here doesn't mean good. It means the presence of unusual experiences that shouldn't be there, like hallucinations.
And just so we're all on the same page, let's quickly define psychosis. It's not one specific disease. It's more of an umbrella term for a state where you've lost some contact with reality. Think hallucinations, disorganized thoughts, that kind of thing. This shared state is the common ground where our two conditions meet. And here, this is where you really see the perfect imposter in action. Just look at this. The symptom lists are practically a mirror image of each other. Persecutory delusions, hearing voices, jumbled thoughts. In this initial acute phase, researchers say they are, and I quote, qualitatively and quantitatively comparable. They're basically the same. And look, don't just take my word for it. The research is crystal clear on this. Back in 2011, Sri Surapanan and his team put it plainly. The initial presentation is essentially indistinguishable. This isn't just a little bit of overlap. We're talking about a clinical dead ringer. Okay, so if they look exactly the same at first glance, how on earth do clinicians tell them apart? Well, this is where the real detective work begins. By digging a little deeper into the data, researchers have found some subtle but absolutely crucial clues. All right, here are the differences. The first cracks in the imposter's facade. So while both conditions can have hallucinations, it's the type of hallucination that's a huge clue. Meth psychosis tends to lean way more into the visual and tactile, seeing shadows, feeling bugs crawling on your skin. Schizophrenia, on the other hand, is much more known for its auditory hallucinations, like hearing voices. Beyond that, the really severe thought disorganization and those negative symptoms, like a total lack of emotion or motivation, those are much stronger signs of schizophrenia. But, and you knew there was a but coming, right? Here's the twist. The story doesn't end there. Over time, those pretty clear lines we just drew can start to get really, really blurry again, especially if the psychosis just doesn't go away. This timeline kind of shows how that blurring happens. So you have the acute psychosis that kicks in right around the time of drug use. For a lot of people, if they stop using for about a month, the symptoms totally disappear. Great. But for some, the psychosis sticks around. And that's where the mystery really deepens. Now get ready for this number. 30%. Let that sink in for a second. Some long-term studies have found that up to 30% of patients who were first brought in for a stimulant-induced psychosis later had their diagnosis officially changed to schizophrenia. This is huge. It suggests the drug might not just be mimicking the illness, but maybe even unmasking or triggering it in people who are already vulnerable. And here's what's even crazier. As the condition becomes chronic, the symptoms actually start to shift. Those telltale visual and tactile hallucinations, they often fade away. And the whole clinical picture starts to look even more like classic schizophrenia than it did at the very beginning. The imposter gets more and more convincing over time. So, we've walked through the mystery, the clues, the investigation. But let's bring this all back to what really matters. Why getting this diagnosis right is so incredibly critical for a person's life and their future. So how is this puzzle actually solved on the front lines? Well, it's a pretty methodical process. First things first, safety. You have to stabilize the patient. Then, clinicians basically become detectives. They gather a detailed history, talk to family, look for any clue about substance use. A toxicology screen, a simple urine test, can give them that hard evidence. But maybe the most crucial step of all is just observation. You wait. If the symptoms disappear once the drug is out of their system, well, there's your answer. Time really does reveal the truth here. And this is why that whole process is so vital. Getting that initial diagnosis right dictates the entire treatment plan. Do you focus on substance use treatment to get rid of the trigger, or do you need to start long-term antipsychotic medication for an underlying illness? Or, as is often the case, is it a really complex combination of both? And remembering that 30% risk of transition, that's not just a statistic. It's a clear signal for careful, long-term monitoring. A correct diagnosis is the foundation for any real effective recovery. So this all leaves us with a pretty big question, doesn't it? Methamphetamine psychosis isn't just some clinical curiosity. It's a powerful reminder of this tangled, complex intersection of addiction and mental illness. As we get better and better at telling these two conditions apart, the real challenge moves from the hospital to society as a whole. How do we build better, more compassionate systems of care that can treat the whole person, not just one set of symptoms?